Well, good morning or good afternoon, everyone. My name is Joy Burkhardt, and it's great to have you all here with us to learn more about maternal suicide, including prevention strategies and crisis strategies. We're thrilled you're with us. We have over 1,000 people registered to join us, so welcome whether you're participating live or watching the recording retrospectively. Thanks so much for joining us. First, I want to start by telling you just a little bit about 2020 Mom. And as I mentioned, my name is Joy Burkhardt. I'm the founder and executive director of 2020 Mom. Our mission is to close gaps in maternal mental health care, and we're doing that by providing opportunities like this to convene change agents. We also provide tools, and we're mostly supporting those of you with lived experience. We know some of you are on the line. Welcome. Public health professionals, and also those champions that work in the health delivery system. I'm going to start now by sharing who's on the line with us. You have a chance to meet our speakers and our guests that will be joining us for discussion at the end of the presentation, including Cindy Lee Herrick from the 2020 Mom team, Jen Beauregard from the CDC. You'll also hear in just a moment from Susanna. Let me get back to that screen. Sorry about that. From Susanna as well. And then we'll hear from Dr. Mary Kimmel from the UNC Chapel Hill School of Medicine, and then Dr. Karen Tabb will be joining us as well. And then Shai Lewis will be joining us from the Lifeline, the Suicide Lifeline. Thank you, Shai. And then we'll hear at the end of our presentation today from Rachel Kenser. Without further ado, I'm going to go ahead and turn it over to our partners at the CDC. I also would like to remind all of you have a chance to ask questions directly as well, and you can do that using the question feature in the GoToWebinar control panel. That control panel is a long rectangular box that usually appears on the right-hand side of your screen. And again, just open that question feature and drop in your questions as we go. Without further ado, I'm going to go ahead and turn it over to Susanna Troust from the CDC.
Great, thank you so much, Joy. Hi, everyone. My name is Susanna Troust, and I am an epidemiology fellow on the maternal mortality prevention team in CDC's Division of Reproductive Health. And I'm honored to be here with you all today. In this presentation, I will highlight data on suicide deaths among reproductive aged women in the United States, provide an overview of data sources on maternal mortality in the United States, and share detailed findings on pregnancy-related suicide deaths identified by maternal mortality review committees in 14 states from 2008 to 2017. Next slide, please. In 2018, there were more than 4,500 suicide deaths among women of reproductive age in the United States, according to CDC's National Violent Death Reporting System. The rate of suicide death increased from 5.4 per 100,000 persons in 2008 to 7.2 per 100,000 persons in 2018. Next slide. At the national level, CDC currently measures maternal mortality data through two national surveillance systems, the National Vital Statistics System, or NVSS, and the Pregnancy Mortality Surveillance System, or PMSS. NVSS tracks maternal deaths defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. PMSS tracks pregnancy-related deaths, which are similarly defined, but extend the time period for postpartum deaths out to 1 year after the end of pregnancy. Records are reviewed by CDC medical epidemiologists to both confirm pregnancy within the prior year and to determine whether the death was related to pregnancy. Both of these data systems provide critical information on maternal mortality in the United States. However, they both exclude deaths due to external causes of injury, including suicide. Next slide, please. State and local maternal mortality review committees, or MMRCs, also have a critical role in maternal mortality surveillance. MMRCs are multidisciplinary committees that review deaths during pregnancy and within 1 year from the end of pregnancy. In contrast with MVSS and PMSS, MMRCs may identify and review deaths by suicide among pregnant and postpartum persons. MMRCs are uniquely positioned to conduct richer reviews that attempt to tell the full story of each person who died. They have access to a variety of information beyond vital records, including social service, law enforcement, prenatal care, and other medical records. MMRCs are also multidisciplinary groups of clinical and non-clinical experts, including maternal fetal medicine specialists, midwives, mental health providers, social workers, Healthy Start representatives, and so many more. We are also continuously working with MMRCs to expand committee membership to ensure representation from a variety of backgrounds and disciplines. The primary purpose of MMRCs is to understand both the medical and non-medical contributors to deaths in order to develop and prioritize clinical and public health interventions that reduce maternal deaths. Next slide. During committee review, MMRCs are asked to determine whether the death during pregnancy or within 1 year of pregnancy was pregnancy-related. A pregnancy-related death is defined as the death of a person during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Often, to answer this question, MMRCs ask themselves, had the person not been pregnant, would they have died? Next slide, please. After determining pregnancy relatedness, MMRCs answer a variety of questions regarding the circumstances surrounding each death, including whether the death was a suicide. MMRCs may use a variety of records to answer this question, including the death record, autopsy report, and police records. If the death is determined to be a suicide, the MMRC is also asked to specify the means of fatal injury. Next slide. While MMRCs currently exist in 47 jurisdictions, I now want to share some findings on pregnancy-related suicide deaths in 14 states from 2008 to 2017. A more detailed analysis of these deaths due to mental health conditions, including suicide deaths, will hopefully be published soon, so for now I'll just highlight a few key findings. 14 MMRCs contributed data to this presentation, so thank you to all of the MMRCs listed here on this slide. These states contributed data from 2008 to 2017, although the years of death contributed by each state varies. Next slide, please. In total, these 14 MMRCs made a pregnancy relatedness determination for 1,259 deaths occurring during pregnancy or within 1 year of pregnancy. Among those deaths, they determined that 453 were pregnancy related. Using the MMRC suicide determination described previously, we identified all pregnancy-related deaths determined by MMRCs to be suicides. For deaths missing an MMRC determination, we used additional abstracted records, including death records and autopsy reports, to classify these deaths as suicides. In total, there were 29 pregnancy-related suicide deaths in these 14 states from 2008 to 2017. Next slide. Among these 29 pregnancy-related suicide deaths, 34% were firearm deaths, 34% were hanging deaths, 14% were intentional overdoses or poisonings, and 17% had other means of fatal injury, such as a fall. Next slide. This slide looks at the timing of death in relation to pregnancy. Most pregnancy-related suicide deaths occurred in the postpartum period, with 62% occurring 43 days to 1 year from the end of pregnancy. Next slide. "21 pregnancy-related suicide deaths had a preventability determination made by the MMRCs, and all of those deaths were determined to be preventable by the committees. A death is considered preventable if the committee determines that there was at least some chance of the death being averted by one or more reasonable changes to patient, family, provider, facility, system, and/or community factors." Next slide. After reviewing the abstracted records for all 29 pregnancy-related suicide deaths, we determined that 34% had a documented prior suicide attempt. Next slide. Beyond identifying and conducting reviews of pregnancy-related deaths, MMRCs aim to influence preventive actions by disseminating their findings and recommendations and promoting the translation of these findings and recommendations into quality improvement actions within their own jurisdictions. This slide shows example recommendations identified by the state MMRCs for these 29 pregnancy-related suicide deaths. Sample recommendations include ensuring that screenings are completed at intake, ensuring that screenings are language and culture appropriate, and prioritizing evaluations before discharge from delivery hospitalization. While the example recommendations shown here are focused on screenings and referrals, there are many more recommendations made by the state MMRCs for pregnancy-related suicide deaths, and these recommendations cover a wide range of topics such as care coordination, access to care, and education. So thank you for letting me join you all today, and I'm happy to answer any questions during the fireside chat. And I'll now pass it to Dr. Kimmel.
Great. Thank you so much, Susanna, and Dr. Kimmel, welcome. We're hoping you can turn your camera on for us, and we'll go ahead and get started.
Oh,
And that's okay. Go ahead, Dr. Kimmel, and you can start. We'll show your camera later. There you are, looking great. Thank you.
So I wanted to share the story of a mom. And actually, when I was thinking about what I was going to talk about today in terms of trying to think about this spectrum or this distinction between intrusive thoughts or kind of obsessive compulsive thoughts and suicidal or homicidal thoughts with intent, I actually, one patient really stuck out to me from my year. So for 5 years, I was the medical director for the perinatal psychiatry inpatient unit at UNC and cared for many women. And so actually I've taken that case, but I've also added in details from other patients that I have cared for over the years. And I wanted to tell this story to get us thinking about this and how best we can empower moms. So the story of a mom. So she had some mild anxiety at times in her life, but she'd always found that things like running and yoga helped her. She actually had also taken a course in mindfulness in college, really enjoyed that and found that very helpful. This was her first pregnancy after undergoing some infertility treatment. Her pregnancy was complicated by gestational hypertension and then superimposed preeclampsia, which required delivery at 36 weeks. And of course, along with that, she had increasing worry, especially around her health and the health of the pregnancy. And I want to have this kind of consistent underlying theme of allostatic load because I increasingly, so my research is actually in stress reactivity and for example, the autonomic nervous system, and have been thinking a lot about this concept of wear and tear over time and how, we all encounter, so stress is really just our adaptation to change. And we have to do that, throughout many different times in our lives, but particularly in pregnancy, there is a huge amount of change that is required biologically, psychologically, socially. And so, so we kind of go in with this level of how we've navigated things, how our stress system has navigated things before, the kinds of things we've come in contact with. We go into pregnancy. Pregnancy itself is additional wear and tear on our stress systems. For example, our autonomic nervous system and our hypothalamic pituitary axis. And then next slide, please. And so that increases the allostatic load. So we have an increasing amounts of it. And for our mom today that we're talking about, she, so in pregnancy, she had the pregnancy itself. She had, representative stress on her system represented by the gestational hypertension. I always tell moms actually when I'm talking about depression and anxiety, hypertension is a great example. We need blood pressure, but sometimes our system kind of gets turned on too high and has a hard time turning itself down. And that's off, that's, I think, well seen. People can understand that's well seen with hypertension, with high blood pressure. And so her story continues. So right after birth, she actually felt really energized, was, doing all the feeds, and even between late night feeds, she was energized, organizing things in the nursery. But then a week and a half after delivery, her son seemed to have some trouble breathing. They became very worried. They took him to the ER. They were unable to get an answer. They weren't able to find anything. Overall, by that point, her son seemed fine. But that really just set off this worry. She started having worries about him getting sick. She started checking on him repeatedly, checking on him in the middle of the night. Then that progressed to, now all of a sudden having these upsetting images come into her head. She'd be giving him a bath, and she'd have images of him drowning. Then she'd be checking on him in the crib, and she'd have images of him, being smothered by his blanket. And that just continued to progress, and her worries got worse and worse, and these images got worse and worse, and she began to wonder why she was having these images, thinking what kind of mom has these images in her head. Her family noticed that she was doing some things that weren't like her. She was turning on the heat, even though the temperature was very mild outside. That wasn't something like her. She started noticing she would stare at things kind of for extended periods of time, and they weren't quite sure what she was thinking or why she was doing that. She stopped eating. And then this progressed again to this level of, at some point, she told her husband that she really thought he'd be better off as a dad alone, and that, eventually he'd find someone new who would be a good mother. And then she asked this son's pediatrician if he was failing to thrive in her care. She really, believed he was, and could not be reassured elsewise. And then at a certain point, this progressed to, and she did tell her husband that she was on a walk. And don't worry, this has a good ending. So this is a treatable medical condition. So I just want to put that out there because this is a setting thing to talk about. But she told her husband that on a walk, and she had walked by a nearby pond, and she had, had her son with her, and she had this image of them walking into the water and becoming completely submerged. And then I want to go back to this idea of our mom's stress system. She's had a number of wear and tear on her stress system, and her system's trying to find balance in the postpartum, and now a new balance of being a mom and caring for this child. And so there's so her allostatic load has really, started to tip over and has become tipped over into this intense depression and anxiety. And I think what's helpful in thinking about this case is there are a number of, next slide, please. Is thinking about, what is, if you, so I am the medical director for a program called North Carolina Maternal Mental Health Matters. And so we work with frontline providers to help assess situations, develop care plans for women, answer questions about everything from medicine to diagnosis to care planning to referrals. And so, let's say that someone calls in about this woman and asks about, well, what is her risk, and what do we need to do? I've heard a lot of times people kind of make this distinction about OCD and postpartum psychosis, and the difference is, whether a woman, whether it is egosyntonic or egodystonic. So is it something that she doesn't see, isn't in line with herself? And I would argue this is more of a spectrum, and but also that there are some things to think about, and that we can help determine the best plan for women. And there are treatable plans in all cases. And in some ways, actually, some of the treatments end up being the same regardless of where someone falls on the spectrum. So we'll talk about that too. But I think some keys to think about are, so in terms of thinking about, is a thought intrusive? Is it a thought that is something that has come, helping women and helping their care providers make some of the kind of understand these, that thoughts are thoughts, using very cognitive behavioral kind of approach where, thoughts are thoughts. They kind of, I think of them sometimes as mom brain, these intense mom thoughts, telling us we need to protect the child, we need to protect ourselves. And in some ways those become sort of distorted and they become these upsetting images. And so, you know, thinking about that perspective, and certainly things that help kind of nudge you more towards an intrusive thought is something like a history of OCD, you know, mom being very clear that these thoughts are very upsetting. And then kind of for postpartum psychosis, which is actually a severe form, I think of it as a severe form. It's an umbrella term. So there's a number of you know, there's probably actually an immune component to it, but we think of it as a mood disorder, so a form of depression or anxiety. And that, so at that kind of, when it becomes more of a postpartum psychosis, you know, there may be bizarre beliefs or actions, you know, sort of the turning on the heat, when it didn't seem like something that she would normally do. It's more common in patients who have a history of bipolar disorder. There would be, you know, if they're auditory or visual hallucinations. But again, all these things are a spectrum. And so it's not one or the other. And so I think it's really important to think about talking with a mom, and what we have seen, interestingly, with the patient that I gave as an example, that over time these things can progress. They can progress from kind of intense anxiety and stress that builds to more intense anxiety, intrusive thoughts. Those can be exhausting for the system. And over time, that exhaustion leads to this depression. And then a depression to the point that you become hopeless and you begin to think that you cannot take care of your child, a delusional component of your inability to care for the child. And this story, as I said, has a good ending. So she got admitted to our perinatal psychiatry inpatient unit. We started her on medication. She was able to, she began to enjoy visits with her family and the baby. She enjoyed having her son there, and the staff was just amazed with how she interacted with her son. She engaged in groups. She particularly found working with the psychology team around her intrusive thoughts helpful in employing cognitive behavioral therapy approaches. She enjoyed and kind of exposing herself to some of the thoughts. You know, if she had an image of using, you know, they had her do things like go to the kitchen and cut up some vegetables to get through kind of these intrusive thoughts. About, you know, sharp objects. She enjoyed talking with the other mothers. She reminded herself of how important that component was to her, to have other women in her life and to talk to them about things. And so that gets us to empowering. And so here are some key things that I want us to think about, and that I think we need to think about from a system level, how we can create more of this. So we need to ensure, in order to make these, you know, really get to know each woman and where she is and what she needs on this spectrum, we need to have time for her, be able to, you know, get to know her life story, and have time to do that. That needs to be done in a team approach. So it doesn't have to be one person, but it needs to be a team of people who are working together and coordinating information and coordinating a care plan. And also coordinating how we're going to work with moms around suicidal thoughts and intrusive thoughts, so that we're giving similar messaging and similar care. And that we also, I think we need to really think about how we balance keeping women safe, particularly in inpatient units. There have been increasing rules and that come from a place of really trying to keep patients safe. But it also, we need to find a balance with empowering women to be able to be in space and to be able to feel like they can be in their usual environment, not a completely sparse environment. And then I just always want to thank the people I work with on the Matters program. Thank you.
Great. Thank you so much, Dr. Kimmel, and we look forward to talking a little bit more about some of these concepts in our fireside chat. Next, introduce Dr. Karen Tabb. And Karen, if you don't mind, we'll turn it over to you. Thank you.
Thank you. What an honor to be with you all. I'm going to jump right in and say, next slide, please.
Oh, okay, I'm sorry, it's a slide.
In my role today, I'm presenting as a researcher. And as researchers, To address suicide risk, we try and learn the extent of the problem of suicidality. So that's any thoughts of death or self-harm. I will refer to suicidal ideation as SI. Most of our research takes place in clinic settings because clinics offer a window of opportunity for intervention, being an intimate space in front of a woman who might be experiencing suicidal ideation during her pregnancy or shortly after. My research team uses depression screens to examine the extent of depression, but these depression screens also include a measure of suicidality, so we examine suicidal ideation and self-harm as well. Overall, in the population, 2 to 5% of women are going to report suicidal ideation during a pregnancy, and 1 in 8 women are going to report a probable depression or elevated depression symptoms during a pregnancy. Disparities exist. If we start looking at research on depression and suicidal ideation among racial and ethnic minority populations, in particular Black women, we find that 10 to 30% of Black women are going to have probable depression during a pregnancy, and anywhere from 3 to 17% of Black women are going to report suicidal ideation. Next slide, please. In some very recent research studies, we are identifying risk factors for suicidal ideation and the differences across racial and ethnic subgroups. We've found that Black women, so this is self-reported non-Hispanic Black women and self-reported Asian women, are more likely to report suicidal ideation at the point of giving birth, the immediate postpartum period, than white women, so non-Hispanic white women. We found elevated risk for these racial and ethnic minority groups that align with other findings. There was a study conducted over the summer and presented at Academy Health that found that there's an upward trend in the diagnoses of suicidality, including self-harm and suicidal ideation. Looking at privately insured women from 2006 to 2017, the trend continued, and the increases were steepest for non-Hispanic Black women, as well as younger women. Next slide, please. And then there's a dire need to have more research now, as we are in the middle of a pandemic. COVID-19 has exacerbated perinatal mental health problems as experienced by populations across the world. We do not have any indication of suicidal ideation and self-harm during COVID-19, but this is dire information that we need to have to inform clinical practices and to identify solutions. If we look across the spectrum, women during COVID-19 are experiencing greater distress, pandemic-related distress, and trauma than they do outside of the pandemic. Next slide, please. In terms of the solutions, this audience is well versed and knows that universal depression screening includes items around suicidality and is an approach to capture the needs of all women, so we can learn more about our non-Hispanic white women, Native American, Indigenous women, Black and Asian women in this country, and identify clinical solutions to provide adequate referral, follow-up, and treatment. In addition to universal depression screening as an approach for addressing SI head-on, we can also have a patient-centered lens. We can work alongside patients to identify what's going on besides that report of suicidal ideation and learn more about plans, attempts, and their use of that tool to communicate their needs. With that, I say thank you, and we'll move on to the next speaker.
Great, thank you, Dr. Tab. I now have the pleasure, and actually you all will receive these slides, let me say. There's some more research that Dr. Tab is engaged in, and we want you to take a look at that in just a moment. And I also want to welcome now Shai Lewis to join us from the Suicide Lifeline. Shai.
Hi, and thank you so much for having me here today. I'm really excited to be here to talk about how the Lifeline can be a resource in times where a mother might be thinking of suicide, and also can serve as a resource to providers and advocates as a referral or support for yourselves as a caregiver. I'm going to give an overview of the Lifeline structure and services in my time today, as well as talk a little bit about what happens when someone calls the Lifeline for support. But first, on the next slide, I want to point you to a disclaimer from our funder that we give when we present. The views, opinions, and content expressed don't necessarily reflect the views, opinions, or policies of our funders, the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Next slide, please. So for those of you who may not be familiar with the Lifeline's services and structure, I just want to quickly go over a couple of points. The Lifeline began in 2005. It is funded by SAMHSA and is administered by Vibrant Emotional Health. And the Lifeline connects people in each state to local crisis centers through the national toll-free number, which is 1-800-273-8255. For those occasions when our local centers are at capacity or may have other limitations in hours or coverage, we have national backup centers that we work with that are available to answer calls that any local centers are unable to answer. And as of today, there are about 180 crisis centers in our network. We use independent evaluations to demonstrate that Lifeline centers are effective in reducing emotional distress and suicidality. We disseminate our national standards for assessment and intervention across the country. And our Lifeline centers have been shown to be able to divert callers from unnecessary interactions with law enforcement, emergency services, and hospital services in many cases. Let's talk a little bit on the next slide about what that looks like. Some folks were interested in understanding a little bit more about what happens when someone dials the Lifeline. So we want to have that familiarity so that you can share this with folks that you might be working with. When someone dials the Lifeline through the phone, we also have chat services available through our website, so instant messaging. If you go to suicidepreventionlifeline.org. But the majority of our contacts through telephone are going to hear this message when they first dial that says you've reached the National Suicide Prevention Lifeline, also serving the Veterans Crisis Line. And I'll explain a little bit more about that on the next slide. But then it continues to repeat the message in Spanish for Spanish speakers. And lets folks know if they're in emotional distress or suicidal crisis or concerned about someone who might be, that we're here to help. It offers folks the opportunity who are U.S. military veteran or current service member to press 1 to reach the Veterans Crisis Line, and otherwise folks stay on the line to hold while we route them to the nearest crisis center in our network. Callers are also able to press 2 or to dial a direct number to reach a subnetwork of Spanish-speaking centers that have operators that are available to speak in Spanish. Next slide, please. So just a little bit about how the routing works, just kind of a little bit of a visual image of that for you. Someone would dial 1-800-273-TALK. So if they don't press a prompt, they'll go to their local crisis center. If their local crisis center is unable to answer, they'll go to our national backup network so that calls don't get missed. If the caller presses 1, they'll be routed to the Veterans Crisis Line. And if they press 2, they'll be routed to the Spanish subnetwork, like I mentioned before. If we go to the next slide, I just want to talk a little bit about our clinical requirements and training so that you have a bit of an idea about who's answering the line when someone calls the Lifeline. All of our crisis centers have to meet the Lifeline standards for safety assessment, for assessing someone's safety, and have required policies in place around addressing imminent risk. And there's 10 different required policies. They work through with our onboarding and certification coordinator on joining the Lifeline to make sure that all of those policies and procedures are up to speed and meeting the Lifeline's guidelines. All of our individual centers provide local training for both new and active crisis center staff and volunteers if they use volunteers in their center. They all are trained in prevention, intervention, risk assessment, and those imminent risk protocols at the local level. And then at the national level, the Lifeline supports all of our centers with interactive web tools, guidance documents, tip sheets, opportunities for simulation training where they practice their skills. We host webinars like this on specific topics and skills. We provide technical assistance and support, as well as opportunities for implementing assist training in their center. We are working with 2020 Mom to create a tip sheet that's specific to maternal mental health to share with our crisis centers. Right now, there's not any particular training unless an individual center hosts it as part of their training specifically on maternal mental health. But all of our crisis counselors have to be trained to be generalists, to be able to work with any individual in crisis and follow good clinical practice in helping a caller to tell their story, to hear what's going on for them, to explore their individual risk factors and help them to create a safety plan. So on the next slide, I'll show you a little bit about what that looks like. So the Lifeline asks our crisis centers to follow this safety assessment model and how they work with individuals who call the Lifeline. The first and most important step is all about connecting. How do we actively engage with the person who's contacting the Lifeline? How do we identify their reasons for calling, begin to build rapport, and help that person to feel safe? Conversations with the Lifeline take place in a really narrative way. It's not the same as someone who goes for, say, a mental health appointment and has to answer a lot of intake questions. It's really led and directed by the person at risk. The person who is calling sort of leads what's happening, and we follow these steps in conjunction with what they need to talk about. Because our contacts are over the telephone or over chat, and we don't see the person and we generally don't know who they are or have other identifying information easily at hand, we need to ask every person who contacts us a little bit about their immediate risk. Have they already taken any action to harm themselves before they dial the Lifeline? Are they imminently about to take action? Those are things that are really important for us to know and for us to make sure that the person is getting intervention if there's an attempt already in progress. If there isn't an emergency situation already happening, we move on and really focus on that listening and helping that person to tell their story and to validate what the person is feeling and providing a lot of extra support. We listen specifically for factors that include the person's desire for suicide, their intent around suicide, their capability to act on any thoughts of suicide, and any buffers or things that are sort of protecting them against suicide, things that are helping them to feel ambivalent or to have something to kind of stay alive for. So we listen for those things as they talk. And when we don't have information that we need to help us to understand their safety in the moment, we also move on to clarify and ask some additional questions to help understand more about what the person's dealing with. As we gather that information about their desire, intent, capability, and buffers, we're looking to move that into making a plan to get that person's collaborative willingness to move forward with us to talk about coping strategies, things that they can do to help themselves cope in the moment, as well as work through developing a safety plan with the person that has several distinct elements that we want to make sure are in place to protect against those thoughts of suicide at whatever level that person was experiencing those thoughts. If needed, so we'll work with that person to get them to emergency resources. if they are unable or unwilling to create that kind of safety plan with us, and there's the sense of imminent risk of immediate harm that may be occurring. And then we'll offer follow-up and wrap up the call. We've moved on to the next slide. I see what just sort of highlights some of the things that our crisis counselors are listening for when they talk to the person at risk. So it highlights some of the elements of things that we want to assess above that dotted line. We want to assess every caller around these areas to help understand what's going on for them and to help determine what kind of safety plan needs to be put into place. And some of the items below that dotted line are very situationally specific for each individual. And we ask our crisis counselors to think through each of those items and review those with their callers to help inform what needs to happen in the safety plan. On the next slide, one of the questions that we had wanted to address, and we can talk about this more in the fireside chat portion as well if folks have additional questions, but there was some wondering about how we handle harm to others, particularly child abuse. And I wanted to highlight that crisis centers do sometimes become aware of risks of harm to others. So sometimes there's threats of homicide or mass violence. We sometimes hear about child abuse or elder abuse, domestic violence. If there is current violence happening during the call, during the contact with the individual, or there's imminent violence that's about to happen, we would need to treat that as an emergency situation and try to intervene in any danger or emergency that's happening right then and there. And then our crisis lines are generally treating themselves as mandated reporters, and many of them, because of their, if they're a clinician, have educational levels that require it, are mandated reporters, and they will need to make reports of any credible child abuse as depending on the laws of their state. So we can get into that a little bit later if there are more questions around that, but I did want to highlight that that is something that we do sometimes hear about. And then last, before we moved on to the next section, I wanted to, oh, we've already moved on. On the slide that just passed, I was just giving folks the idea that if you're looking to help someone thinking of suicide, you don't have to be a Lifeline counselor. You don't have to go through a crisis counseling training program. There are lots of screening forms that other folks talked about earlier, as well as some good things for any person to learn by checking out our Be the One To website, which their address is down at the bottom, and it goes through 5 different steps that any individual can use, and they're great to keep in mind in the moment. So if you come into contact with somebody who's thinking about suicide, there's just 5 simple steps to take, and you can learn more by checking out that website. And that brings me to our next speaker.
Great, thanks so much, Shai. Really important work that you do. We're going to turn it over next to Rachel Kenter from the Suicide Prevention Resource Center. Rachel, thank you for wrapping up, and then we're going to have a short fireside chat, and we have a few questions that have been coming in already, so keep them coming in, and we'll make sure we address them in the chat. Rachel.
Great. Welcome. Hello. I am Rachel Kenter. I'm from the Suicide Prevention Resource Center. It's the only federally supported resource center devoted to advancing the implementation of the National Strategy for Suicide Prevention. Next slide, please. And you can just go right through to the next slide. This is the same disclaimer that Shai had. So she already read it for me. So we know that there are a lot of contributors to suicide risk, and anticipating the birth of a child can be a really exciting time full of hope, but it can also create a lot of stressors that can have a negative impact on someone's potential risk for suicide. And so it's not just about the person's mental health. There are a lot of other things that can contribute to suicide risk as well. So next slide. So there are 3 kind of components to SPRC's effective prevention model. One is strategic planning, and that's to determine the problems and populations where to focus, identify activities that'll prevent suicide, And then we also have keys to success, which is engaging people with lived experience. So if you are thinking about planning a suicide prevention model or program, include people that you know who have had lived experience, because they can offer a wealth of knowledge. Partnerships and collaboration, so working with others who are in this space. Safe and effective messaging and reporting is very important for suicide prevention, as well as culturally competent approaches, making sure that what you are doing is appropriate for your audience. And then finally, evidence-based prevention. And the last thing is a comprehensive approach, and that's what I'm going to go into today. So next slide. So effective suicide prevention is comprehensive. It requires a wide variety of efforts to work together to address suicide prevention. And it's comprised of 9 strategies in our model to reduce suicide and increase mental health. So each strategy is a broad goal that can be advanced into an array of things. So I'm going to go into a few of them today with regard to maternal health. So next slide. The first I want to talk about is identify and assist. So many people in distress don't seek out support on their own in general for suicide. So identifying people at risk for suicide can help you reach those in greatest need and connect them to care and support. So things like gatekeeper trainings, what Shai just mentioned about Be the One Too is a great source for a large variety of people to be trained, suicide screening and teaching people warning signs. So we suggest that people are screened for anxiety and depression for all pregnancy and postpartum period. This can be at a variety of places, the OBGYN provider, any primary care visits they have during that time, and also the pediatrician's offices. Current American Academy of Pediatric recommendations include postpartum depression screens at 1, 2, 4, and 6-month well-child follow-ups. And you may also want to consider screening people who have experienced a pregnancy loss, a stillbirth, or death of a child, as they may be at an increased risk. Next slide, please. The next thing you may want to focus on is enhancing life skills and resilience. By building people's life skills, such as critical thinking, stress management, and coping, you can help prepare them for changes that may come as a result of childbirth, things like economic stress, relationship issues, having a baby in a pandemic, for example. So resilience is the ability to cope with adversity and adapt to change. And that's a well-known protective factor for suicide. So for people in pregnancy and postpartum, this might include physical health, just making sure people are physically healthy and exercise. Sufficient sleep is also very important. And I know that Dr. Kimmel had alluded to that earlier, that those sorts of things are really important to enhance resilience. So this is a really sort of internally focused strategy, but the next one on the next slide is more externally focused, what you and your communities can do. So next slide. And this is about promoting social connectedness and support. Supportive relationships and community connectedness can help protect individuals against suicide despite the presence of risk factors in their lives. Connectedness is a well-known protective factor for suicide prevention. So social programs that increase being together or a sense of belonging, that reduce isolation, and that foster emotionally supportive relationships are really important. So these can be sort of very practical things like having family support or friends who are supportive of someone who recently had a child or is pregnant. Mentoring from an experienced parent can also be helpful, that, these feelings of you're not alone, these aren't, this is a normal stage, you will eventually sleep again. Home visiting programs can help as well, having somebody check in with that mother beyond that 6-week postpartum visit. Lactation consultants could also be pulled in here to help screen and identify women, and another source of connectedness. And also there are so many community organizations that do work with young mothers or new mothers, and making sure that they're well connected. Now in the space of the pandemic and physical distancing, a lot of these can and have been shifted to online platforms, and we would encourage people to continue to work with those in their communities in a virtual way. And we'll go on to the next slide. So we also want to make sure that there is effective care and treatment. So for those of you in behavioral health and healthcare settings, adopting the Zero Suicide framework, making sure that your staff is trained in safety planning and counseling on reducing access to lethal means. So having those conversations with patients or clients, and then having a strong and robust community referral system for treatment. And there's a lot more on that in various places. Next slide, please. So I want to just remind you that this is a comprehensive approach. Not one strategy is going to be effective. We need to take a multitude of strategies to reduce maternal suicide prevention. And the next slide. Thank you very much. And we can turn it over to the fireside chat now.
Yes, great. Thanks, everyone. We have been receiving some great questions and are about to all turn on our cameras here. All right. Well, thanks again to all of our speakers. I'd like to start by just recapping what I've heard, and feel free to ask questions if you still have some questions that haven't been answered today. First, I wanted to share that I heard a few things in our opening remarks from the CDC. I heard that maternal mortality review committees are really the place to start, and that 14 states have been reporting their review committee results on maternal suicide, or including maternal suicide when available. There's more work all of us can be doing to advocate for change in those states that weren't listed on that slide that we saw CDC present. So thank you for that punchline. I also heard that from our two clinicians that there's something about being at risk for suicide that's different than having ideas about suicide. So ideas or ideation doesn't always equal risk. So thank you, Dr. Kimmel and Dr. Tabb, for talking through a little bit of that. Dr. Tabb, also thank you for bringing up that there are important nuances we need to be considering with women of color, BIPOC communities in particular, Black women and Asian women who we don't often talk about, who have higher rates of suicidal thoughts, which again may not mean that they are at higher risk for self or infant harm. We want to unpack that just a little bit in the chat. And there were also some really great points around prevention and programs that we think many of you are involved in already around home visiting, and peer support is coming up in the chat. And there's really important work that peers should be doing and can be doing. There's information, 2020 Moms helping to lead in this space, that you can find on our website. So with that, I am going to ask a question. First, starting with, I'd like to start with you, Dr. Tabb, to ask you if you can comment on how do we manage these very difficult situations with providers who may have a requirement to report potential risk for suicide and infant harm, maybe with Dr. Kimmel's lens around suicidality and sort of risk. This is a really important one. In particular, we know that women of color may often suffer from babies being taken away from them. Suffer is not the right word, but we see more incidents of that happening. Can you talk through any thoughts that you have around, is it provider education that we must focus on to make sure that providers don't call unnecessarily and instead work on treatment plans?
We have to take it off of the providers first. I'm going to wait for Dr. Kimmel to respond. I'll just say, a lot of my research, we build registries to collect data over time from medical charts, and we work with clinics to devise a safety protocol. However, at the state level and the local level, there are guidelines for those protocols, many of which require clinicians to call 911 with a positive pregnancy screen, knowing that it's not the right thing in the moment. It can escalate a situation. So I'd really love to hear suggestions from Dr. Kimmel. We're on the front end of identifying them, but what happens is where we need a lot of systems level work.
Thank you, Dr. Tabb. Dr. Kimmel, do you have anything you would like to add? And Dr. Tabb, I've certainly taken note, Joy here at 2020 Mom, about registries and protocol for mandated reporting, and maybe there's some opportunities there around advocacy and policy change. Oh, and let's just make sure you're unmuted. Hold on just a minute, Dr. Kimmel. Let me make sure we don't have you muted.
You should be unmuted now.
Oh, it is now. Okay.
Great.
Yeah, thank you. I think, this gets back to some nice themes that came out in our across the presentations in terms of I'm particularly thinking about connectedness and community. And so I think we have to make sure that we're taking time to get a lot of information, and that we're getting information, we're pulling in supports of people. As I like to say, when I tell patients, I tell them I want to support the people who support you. And so I think all of that is really important in making these and doing that before, to get the information and figure out what the plan needs to be, and that, and engaging the patient and engaging the family are key, the family or whoever the supports are for that patient. And that helps in terms of, I think with reporting, there are certainly situations where it's really important, if you're feeling like the patient and the family are not engaging in care or cannot engage in care for different reasons, and need greater support. But hopefully we can do that by, having people feel listened to, and not jumping to also that these thoughts that they're having are meaning action. And I think that's important for patients to understand that too, that their thoughts don't mean action, but also for us to take thoughts seriously, that when moms are struggling, we also don't want to go to the other extreme and be like, oh, that's just your intrusive thought, so it's this balance and really giving space for people and the people around them to communicate and to think about what needs to happen.
Great. Thank you, guys. Just also, there's questions from some folks that I think are new to the community, and welcome, about where to find tools for screening. You can find information on the 2020 Mom website. We also have some other great partners. Postpartum Support International is one, but take a look. You can start at the 2020 Mom website. There's some great screening tools. I also just want to share that screening is not common. So it's recommended by, we heard Shai talk about the American Academy of Pediatrics, the American College of Obstetrics and Gynecology, the American Medical Association. These entities are recommending screening, but it's not yet universal because it can be challenging to provide treatment and find treatment resources and referral pathways. We're all working to change those gaps or close those gaps and change those outcomes. But you can find, we need you, those that are asking, we need you as champions to help implement change in your system. So we're here to help. I also want to tie off with one last question, and then we'll ask each of you if you have anything burning that you want to share before we wrap up. One last question again, Dr. Tabb, this one's for you. A great question came in about actual suicide, and I think Jen and folks from the CDC may also have, Susanna, have thoughts on this, is actual suicide completion rates. Do we see nuances around, for example, white women that are completing suicides more often? What are the nuances and what are the data showing there, just for people to keep in perspective? So, and Dr. Tabb, CDC, go ahead.
Our research is looking at suicidality in clinics. So we're just seeing the precursors. We do not know the extent and where these women end up. So this is definitely a CDC question. So I'll pass it to Anna or Jennifer. Thanks.
Yeah. Yep. And I'm happy to say that what we have found is Joy at CDC jump in here as well, that we're looking at both research and we've been following some of the MMRC data. Illinois, California, Massachusetts, I believe Colorado have reports out that we've dived into, and we're seeing that and again, correct me all if you have a wider lens, but what we've seen is that it does appear that white women or Caucasian women tend to complete suicide more often than other races. And again, limited data here. I think in many cases, there was one large study out of San Francisco that was published a year and a half ago on insured women. And Dr. Tabb, I don't know if that was the study you referenced earlier, but that's what I'm seeing. Again, want to open it up to CDC and any others who have data that they want to share. And this will be a great thing, a great blog post, I think, for 2020 Mom to ask some of these team members to join us in authoring so we can make sure we have a tight answer there. And CDC, anything you want to add?
Nothing really specific to add from us. You know, our data is so limited at this point. We have the data from the 14 states, and we do know the racial distribution of those deaths, and they are majority white, non-Hispanic women. The other burning thing that I would add at the end is that what we are really looking forward to is that at CDC, we are funding now 25 MMRCs in 24 states. And so in the next couple of years, we're really expecting to get a lot more data so that we have a better picture at the national level. And that will be focused, you know, what our data focuses on is deaths. And so it is limited to completion. But I hope that we'll have more data to share in the future.
There's one giant caveat that I'd like to take away from the CDC, and it's more critical. And this is in terms of death reporting and race. We know that in our maternal mortality crisis in this country, Black and Indigenous women are 3 to 4 times more likely to die. We know separate, in terms of research, that there are major discrepancies in how race is recorded at death. Well, that's a different part about multiracial people, but the cause of death and what is listed. So we really need to start digging into those unintentional injuries and homicides around the timing of pregnancy. Our research in Brazil 2 years ago found that among those women with suicidal ideation in clinic, almost 80% of them were experiencing violence in the home. So we start looking at those violent deaths and those unintentional injuries, and maybe looking at the classification of suicide, more of the disparities might emerge. And that goes with all of our national bias and how we're seeing death in this country.
Great. Thank you so much, Dr. Tabb, for that remark. And we are over time. One suggestion that's come in is, can we have a part 2 and do a little more fireside chat, and also hear a little bit about the Zero Suicide initiative, and that's what we're doing in the health delivery system to address suicide and the alarming rates that are rising across the country, not just in our population. So I think there's more to tackle here. We will invite some of our speakers back to a part 2, and thank you all so much on behalf of 2020 Mom and the very large audience that's been here to watch you. Thank you, all of our presenters today, for all of your important work and what you've contributed thus far. We will be in touch, everyone, and the recording will be sent out along with the slides and some additional resources that we have available on suicide in the next 48 hours. Thanks, everyone. Enjoy the rest of your day.